Well, again, let's continue on the cardiovascular theme, and obviously our hours are closing, so it's again a pleasure to have been with you, and I wish everybody safe travels back home, and if you're staying over the weekend or more days, enjoy South Carolina and Kiowa. While we're getting the slides up, I also want to say that something did come up over the last couple days in the hypertension field that was out of the blue, and many of you, I thank the members of the group that came up and asked me this question during the break period. There was an alert, and it's hit the internet, regarding one of the antihypertensive medications, valsartan, and then of course what the internet does is, cardiac medication causes cancer. And the answer is yes, there's been an alert. The drug valsartan, an angiotensin receptor blocker, is one of our tried and true angiotensin receptor blockers. The issue, and I've read now extensively because I told some of the members my little email has been ringing off the hook, if you will, if you remember that old saying from emails from obviously our global initiative. As you'll see, many of our countries use valsartan, so I've been getting calls and emails and texts from every place under the sun. It appears that, yes, that it's not the valsartan, so I want to reassure everybody that it's not the drug, the valsartan. It was in the manufacturing process of three, I believe, generic houses, very tried and true, large generic houses in the United States, with obviously outstanding quality control methods, but nevertheless there's an adulterant. There appears to be a small amount, a minute amount of an adulterant that is at least theoretically a carcinogen, and the FDA has put out an alert. Obviously the manufacturing houses, I'm just assuming this, have stopped manufacturing, looking at their methods, their processes, et cetera. And my feeling is this will be corrected very, very quickly, but in the interim, if you start getting calls, go ahead and check on the sites, and it'll explain it to you so you can explain it to your patients. I think what I would do and what I've been suggesting over the last couple of days is if someone is on a valsartan generic prep and if you can tell it's not one of these three houses, that's fine, just continue it. If it's the branded valsartan, absolutely continue it. It's not the branded valsartan from the primary pharmaceutical company. But if you are on one of them or you just don't know, I would just switch over to the branded valsartan until we get further notice and or this settles down. Maybe a little bit more, I don't know, the cost factors should be relatively minor, but you never know. But that would be my suggestion, or switch to another ARB. They're all about the same, although I'm going to give you some preferences in the next couple of minutes. I'm talking out of both sides. But most of the ARBs are interchangeable with dose equivalent, with blood pressure dose equivalency. And if you want to call me or ask me or email me, I can help you through the process. I don't think this is a big issue, but I wanted to make sure we understand it's not the valsartan. So you can reassure everybody about that. It's the chemical process of some of our generic houses. So if you want to talk to me about that further, please feel free, but check the internet. We have many, many, many patients on valsartan, not only in my center in Columbia, but now throughout the world. It's tried and true. It's been long-standing, and it's outstanding ARB, as I'm going to show you and talk through this. Well, let's have some fun for one of the later sessions. I saved this one really for the later one because this is like sort of guess what you're thinking. I kind of picked some things just to think about, sort of a potpourri from hypertension to cardiac to stroke, and just what I thought was some of the within the last 12 months or 18 months issues. I'll continue the hypertension theme regarding the fixed dose combinations and get a little bit more granular with you during the sessions. Again, you take these slides home and hopefully they're reasonably explanatory. I'm not perfect, but nevertheless it's more or less a guide for you how you choose drug classes, whether you use them in combination or not. It's the same principles. And they're going to get into agents within those selected classes. Are there theoretically better ones versus less better ones, et cetera? And again, this is not according to cost, et cetera. This is according to science. But any antihypertensive medication you prescribe is better than no antihypertensive medication. So the right answer is there is no wrong antihypertensive medication that's available to us because they're all safe, effective, and obviously approved. Well, let's look at the learning objectives are in the three categories: category of hypertension, category of stroke, and category of just cardiac diseases in general. Let's continue the journey through hypertension and through the premise that we want to increase adherence and decrease clinical inertia. Several of you came up to me over the week about clinical inertia and gave me outstanding examples from not only, if not your own practices, your own communities. So we know it's out there and we know it's all of us. So let's discuss and emphasize newer treatment modalities and maybe some of the algorithms that we can use, et cetera. I guess I'll try one last time from the pulpit up here. We must be using standardized formularies. We can't choose from 140 drugs. There's no need to do that. We should be choosing from very, very few antihypertensive medications and classes of antihypertensive medications. We must have an algorithm. If we're not using blood pressure algorithms, and again, this is completely heretical to me to say these kind of things, we really aren't practicing really good standardized medicine. And we need to be using, of course, where we can, fixed dose combinations, et cetera, for clinical inertia adherence, timeliness to getting blood pressure control. It's not just achieving blood pressure control, it's how long it takes you to achieve blood pressure control. Strokes happen while you're controlling the blood pressure. In that process, the faster you lower the blood pressure, again, with exceptions, our older populations, et cetera, we want to be a little bit more slow and careful, but the vast majority of our hypertensives, it's the time to achieving blood pressure control that's as important to achieving a control at all. Of course, we want both. We want our cake and eat it too. Well, remember we showed this slide regarding the barriers of blood pressure control. They haven't changed in the last couple days. There's generally been no new barriers other than the new news about the adulterants in some of our valsartan populations, but it's the same big three that we control, that are under our domain. Poor adherence, lack of adherence to current treatment guidelines. Even when we have treatment guidelines, we don't follow them largely. Many of us try, of course, but we're all busy, and there's dueling guidelines even within disciplines. And there's so many guidelines now, just like this whole week, I can't keep track of them all, and I need help. I need help from my colleagues, my subspecialists, and et cetera, to guide me through my practice. And yes, I still do practice. And then we have complex medical regimens that really there's no need for the complexity in most cases, particularly in my discipline, in cardiovascular disease and or hypertension. So let's go ahead and focus on those premises, if you will, and just explore a little bit more granular what we started talking about in the very, very first session this week. This is the foundation of our worldwide global hypertension control program, which started out as the standardized hypertension treatment program. It's now morphed with the CDC it was so successful that the CDC asked to use this program, the hypertension program, for cardiac disease in general, and it's now called the Global Hearts Program of the CDC. So it's already demonstrated success, and this is only its 5th anniversary, but the foundation has not changed of the program, whether it's diabetes or hypertension, et cetera. The foundation is to develop a core set of medications, a formulary, if you will, and that could be a formulary or in your individual practice. It could be in a group practice. It could be in a health system. Or it could even be regionally, nationally, and globally, if you will. Determine which medications are widely available, not only manufactured, but manufactured appropriately, but also inexpensive, et cetera. And then improve the delivery and the medication and the use of these medications in your practice. Pretty simple. So this is not Nobel laureate material, but this is whenever we go into a new country or a new city or a new state or a new hospital system, this premise never changes. It's been demonstrated to be successful. And success is based on time to blood pressure control and overall blood pressure control. And we're still using the JNC7 guidelines of less than 140/90. So we're treating individuals greater than 140/90, and we're lowering the blood pressure to less than 140/90. And yes, we are in the presence now of layering on cardiovascular risk within that population, but the premise is the same. Well, I was asked to form a small group or join a small group 5 years ago to develop a worldwide formulary. This is a daunting task. And again, this was from the CDC and the World Health Organization. They said, Dr. DiPette and your colleagues, we're going to lock you in this room, and we're not going to let you come out of this room until you come up with a consensus agreement on a worldwide global formulary for the control of hypertension. With those premises, simple, affordable, widely available, being able to be manufactured, et cetera. And here's what we came up with. This is fluid. It may not be the agents you agree with, et cetera, because there's nuances in here. I can tell you why one was picked and not another. This is always changing. And again, it's an example for the global treatment control program. It's not rigid. These can be changed, malleable, regarding according to local culture or drug availability or expense. So this is not for, I would not want you to follow this necessarily right now, but it is where we are. So let's just take a diuretic, a thiazide-like diuretic. We came up with, where possible, a primary. If we had our wish list, this is the one we would want everybody in the world to use. And of course, there's a backup drug. So here's how it goes. Chlorthalidone, there's no question in our thiazide-like diuretics that chlorthalidone is the preferred diuretic. It's more potent, it's longer acting, it lowers blood pressure at equal doses to a far greater extent than hydrochlorothiazide. So why have we been using hydrochlorothiazide all these years? Because that's what we started, kind of what we started with, that's what's available, it's inculcated in our culture, it's easy, it's cheap, etc. Chlorthalidone is also generic, it's reasonably widely available, not as widely available. So in any event, that would be an example. For instance, the ACE inhibitor. We decided on lisinopril. And again, none of us have any conflict of interest. These are for nonprofit, major, altruistic, if you will, organizations, the WHO and the CDC. So the primary drug was lisinopril. The backup drug was enalapril. I strongly opposed enalapril to be the backup drug. But why? Because it's got a short-acting duration. But why is it? Because there are some countries that do not make lisinopril. Most do, though. Most are widely available. We had the Bolivian contingent with us in Miami, and in Bolivia, only enalapril is available, et cetera. We had the Cuban contingent where only enalapril was available. It was very much fun. They just said, the health minister told me, he says, Dr. Petty, what ACE inhibitor do you want us to make? And I said, lisinopril. They said, fine, I'll just order it tomorrow. And that was it. That's the end of that. So in any event, these are just examples. And you can see here's the ARB, losartan, only because it's inexpensive. It's too short acting. It would not be my preferred ARB, as you're going to see. Valsartan was the backup. I would have had valsartan as the primary drug, but it's a little bit more expensive and a little less available globally because we had a matrix of global production by country, region, continent, et cetera, and so on and so on. So you can see here amlodipine. There is no backup calcium channel blocker because the evidence is solely with amlodipine and it's widely available. So that's kind of interesting. We put a beta blocker on the formulary, not because we want you to use it in hypertension, but because we felt there should be a beta blocker on the formulary for concomitant diseases, migraines, heart failure, coronary disease, because of obviously the frequency of comorbidities with hypertensive individuals, but not for the treatment of hypertension. That was other than a fifth or sixth drug. And we put spironolactone on the formulary for a fourth agent in our algorithms. And again, as you can see, there's no backup. You could put a pilironone in there or switch them back and forth, but it's much more expensive, so we felt globally it just wasn't going to make any sense. So I'm just giving you some ideas of how we came up with this. And this has obviously been adopted, but it's also a work in progress and it's fluid. And I'm going to change all of this for you in a couple minutes because I've just been asked to do something completely different. And then we actually put combinations. And then we actually dreamed. They said, take some time and make a wish list. Like if you build it, they will come. So if we recommended it, would manufacturers around the world start making it? And we came up with some ideal combination, including a triple drug combination of an ARB, the diuretic chlorthalidone, and calcium channel blocker, that would be amlodipine. And that was just kind of like dreaming. There isn't one. But that was kind of like putting it out there. Let's get it published. Let's put it worldwide and see if anybody wants to step up to the plate and make it. This has been so successful that we can get these medications per pill at maximal doses for thousandths of a penny. Unbelievable. It's just been a remarkable process, and it's been enlightening to me. Because if you put lisinopril out there as the worldwide ACE inhibitor, it's going to be very, very cheap when you start treating 1 billion people around the world. So we can now get it for 1,000th of a cent. I don't even think we monitor the cost of the medications anymore. That's just been fun. We talked about this. If you're going to do single therapy or combination therapy, these are the 3 major classes, of course. And within the RAS inhibitors, the renin-angiotensin system inhibitors, it's ACEs or ARBs. So that's pretty straightforward. On the formulary and our algorithms, the 4th drug is spironolactone. So if you start with a diuretic, you add an ACE inhibitor, does still not go at goal, you add a calcium channel blocker. And then one way or the other, you get to an agent within these 3 classes if you need it. If you need a 4th drug, add spironolactone. It is very, very, very simple and very straightforward. If you want to start 2 of these drugs, we said we already did that the other day. You could start a diuretic and an ARB. You could start an ARB and a CCB. The only one we don't prefer is this one, only because lack of evidence. So we're going to go a little bit more deeper into this regarding specific agents within these classes, because that's what I've been asked to do next. So we already talked about if you wanted those 3 classes of drugs is combinations. We would prefer, if in the RAS system, we'd prefer an ARB over an ACE because they're better tolerated. But if cost is an object and an ACE is more available and much, much cheaper than the ARB, obviously that's a perfectly acceptable alternative. But now what I've been asked to do is what about within the classes of drugs? Not just the major classes and not just a formulary, but what agents would we prefer if we should be so bold as to publish a preferred single agent list for each of the preferred classes of agents, if you will. It's taking it one step further, and then the combination of these preferred agents, again, taking into account if they're available, how much they cost, et cetera. But I've been told to ignore cost, and I've been told to ignore, at this point, availability, because if you build it, they will come kind of authority. And ultimately, it's locally decided anyway, and as long as it's on the list and it's preferred or acceptable, then it's absolutely okay to go with whatever agents, whatever combinations the local community experts, consensus, health ministers, governments, et cetera, want to decide. So I've already been asked some of these questions during the week. If the class of, within the renin-angiotensin system aldosterone inhibitors, if ARBs are the preferred class, only because of tolerability, doesn't mean you can't use ACEs, because of course you can. Right? What about within the ARBs? There is no question that azlosartan is the most potent and the longest duration of action. However, it's still branded and it's expensive. But again, I was told, just let's put that aside for now. Let's just do what we think is best. So the preferred ARBs would be azlosartan. Next would be telmisartan. These are both long-acting, but azlosartan is more potent of the 3. Valsartan has a sufficient duration of action. Totally, it's preferred. If you could afford azlosartan, it'd be better. But we're talking about small differences, but nevertheless, my charge was to list them. And then all other ARBs, except, if you can avoid it, losartan, because it's short duration of action, and probably should be given BID, even though it's approved for once a day. I did the losartan study for FDA approval, and I can tell you it just squeaked by for FDA approval because it met the criteria, but really it kind of wears off in the early morning hours if you're giving it that morning. But nevertheless, and I would also avoid at this point in time olmesartan because there's some enteropathy issues, but they're extremely rare. In Chile, they use olmesartan. Nothing's wrong with that. But if you really ask me to give you a list and ask you what's the best, what's acceptable, and what might not be preferred, here it is. What about ACEs? Well, lisinopril is so widely available. It's long-acting. It's tried or true. Lisinopril would be the ACE. Now, the class is acceptable versus preferred only because of tolerability. You could turn these around and justify it perfectly easily. So we will put lisinopril, and all other ACEs are totally acceptable with the exception of enalapril and captopril because of their short duration of action. So any other ACE that's once a day, that's long-acting, absolutely acceptable. And remember, but if you asked me to pick one for everyone kind of thing that's available, cheap, inexpensive, it would be lisinopril. What about calcium channel blockers? Well, there's really only one class that's preferred. That's the 1,4-dihydropyridines, the nifedipines, felodipine, and really the only agent that is preferred is amlodipine because of the evidence-based medicine. The All-Hat trial used it. Obviously, that was a pinnacle, trial. So we have solid evidence-based medicine with it. It's widely available and it's inexpensive. So we didn't list any others. But if somebody wanted to use a long-acting nifedipine, fine, absolutely fine. We're just giving what we believe is a hierarchical approach, a very standardized approach. The non-1,4-dihydropyridines, there's two other classes, diltiazem and verapamil. They have their uses. In fact, Dr. Piziak didn't mention, or I thought it would come up, but verapamil has just gotten renewed interest in diabetes as being better, perhaps, for, I think it was type 1 diabetics, Ronnie. I'm not positive, but that came out of the blue, and I didn't know that, but okay. But this is for hypertension. But in any event, these two classes are not preferred. Why? There's less evidence-based medicine with them, and they have more complicated side effect profiles, which what's good for one thing might be bad for another, but for hypertension, their cardiac effects, negative inotropic effects, negative chronotropic effects, bundle branch, SA node inhibition and AV node inhibition makes it a little more complicated, but for other disease states, they're the preferred CCB. We already heard Dr. Wagner mention a patient that if you're coming in with a rapid ventricular rate and atrial fibrillation, diltiazem is a drug of choice. So everybody's got a little bit of a niche, but we're talking hypertension. This makes it very easy. So in your CCB class, the 1,4-dihydropyridines are preferred, and there's one agent, amlodipine. And I already mentioned the thiazide-like diuretics. There's only three different groups. Chlorthalidone is preferred, and I would say strongly preferred. If you can use chlorthalidone in your practices as opposed to hydrochlorothiazide, you'll control more blood pressure. Guarantee it. So try to switch over to chlorthalidone. We're having a very difficult time, but we are slowly doing it in Columbia. I'm trying to have all of Columbia switch from hydrochlorothiazide for hypertension now to chlorthalidone, and we're having some success. We'll get about 5 to 10 millimeters of blood pressure reduction more in the entire population of Columbia if we only do this one thing. Hydrochlorothiazide, perfectly acceptable, but it's got half the duration of action as chlorthalidone. Remember, chlorthalidone is half the dosage, too. So 25 milligrams of hydrochlorothiazide is 12.5 milligrams of chlorthalidone because it's more potent.
Why the pushback on chlorthalidone?
Availability and cost. It's a little more expensive. They're both generic, but since it's not as widely, the volume of chlorthalidone is not as great as hydrochlorothiazide, the cost generically is still more expensive. That's the pushback. And not every pharmacy, if you will, stocks it, but that's changing very, very rapidly. And then indapamide, perfectly acceptable, but it's more costly and widely available. In Europe, it's obviously it's a diuretic of choice, but nevertheless, we're talking about the world and globally. So we already talked about this. So now you can put the two together, the first lecture and this lecture together. What about fixed dose combinations or single pill combinations? Because not everything comes in a fixed dose. It's okay to use single pill combinations. You can use one pill of this and one pill of that and give them at the same time. It would be better if they came as a fixed dose, but not all of them do. This was the next charge that I was just given, was to come up with now, so just integrate the two. Integrate the two classes, this presentation we had with now the agents within each class presentation, and you can do this as easily as I can. For an ARB-CCB combination, which is the preferred combination, it's azlosartan or telmisartan or valsartan plus amlodipine. Pretty easy. For the ACCB, it's lisinopril. I put another long-acting ACE inhibitor in here just to be, I guess, fair, if you will, plus amlodipine. If you want to use an ARB plus a thiazide-like diuretic, it's same, these three, plus chlorthalidone. If you can't get chlorthalidone, or there's hydrochlorothiazide. So now it's really almost like a Chinese menu. You're layering them together, and you're picking one from one from column A and one from column B, and pretty soon you have a meal. ACE inhibitor, thiazide-like diuretic, it's just, you could do lisinopril, or you could put lisinopril, another long-acting ACE inhibitor, with chlorthalidone or hydrochlorothiazide. And for the last group, a CCB thiazide-like diuretic, well, right now we're just saying not preferred because of not enough clinical evidence, but if that's the agents you have and that's available, absolutely. I can think of one for this conference. I can think of one area where this would be absolute. If you've got a young or a woman of childbearing age that's attempting to become pregnant, that doesn't want to use oral contraceptives or long-acting contraceptives, as I've now been taught while I've been here, that would be a perfect combination to use. As the exception, though, not the rule. And again, I showed you this. Kaiser Permanente has been doing this in some shape or form for a very, very long time, almost now 10, 12 years. They do still have the same guideline. The goal of anyone over 140/90 is less than 140/90. And they use fixed dose combinations of lisinopril and hydrochlorothiazide. I've talked to the leadership of Kaiser Permanente, and I would like this been chlorthalidone, or I might like it to have been an ARB instead of the lisinopril, but this is what they can get, and this is what they can get in mass quantities, because they got 4 million people they are treating out in California, and it works. If obviously this doesn't work, you go to calcium channel blocker, your third drug. If that's still not at goal, you add spironolactone. Notice they do have the thiazide diuretic here, et cetera, if pregnancy, for pregnancy potential. And here's their control rates. Within immediately starting the program in 2001, this is them. They're progressing. Look at the sharp jump when fixed dose combinations came into play. Their control rates are now 80% or greater. I saw the last data just 2 weeks ago. It's now 91%. They're actually pretty close to approaching hypotension. They do not want their control rates to go higher, because now at around 90%, if you're less than 130/80, by the way, their average is 127/78. They're getting close to, I don't know how much more they can do, but they're still trying. And here's what we're doing globally to show you that we've taken this program obviously abroad. The 4 centers that are up and running right now are Barbados, Chile, Colombia, and Cuba. And there's a lot of hurdles we want them to hit. But one thing I want to show you is every one of their formularies is standardized. It includes those single, primary, and secondary drugs. They can be different among countries. That's okay. All politics are local, as long as they're in the preferred or acceptable categories. And all 4 countries are starting with fixed dose combinations. In Barbados, they're using lisinopril and hydrochlorothiazide, like the Kaiser Permanente protocol. In Chile, they're using valsartan and amlodipine. In Colombia, they're using losartan and hydrochlorothiazide. And in Cuba, they're using hydrochlorothiazide and enalapril, only until they can get the pharmaceutical companies to change from enalapril to lisinopril. And this probably will be lisinopril, but probably by then they're going to be switching to an ARB and a CCB, because we have time. So it just goes to show you that we're doing this. We're doing this with large populations. And now I'm going to show you the results. As I already told you, that the standardized hypertension program has morphed to global hearts and Hearts in the Americas program. Barbados was already a pretty We call them low to middle income countries, but Barbados is more middle income to high, depending on where you are in Barbados. We did this at the university, so it was largely high income. Their control rates even went up, but they started high. They started around 53, 56% and went up to around 60-ish%. But that's because they started with a pretty high bar to begin with, but the others did not. The other initial control rates were anywhere between 13% and 35%. In Cuba, for instance, in the province of Matanzas, we took 26,000 inhabitants. The blood pressure control rate increased within 6 months. Talk about clinical inertia or no clinical inertia. Once the formulary was in place, the algorithm and the fixed dose combinations were available, from 35% to 70%. I've seen the recent data, it's over 80% already. And it's going it's going nationwide in Cuba. In Colombia, the city of Cali, we had 2 sites, very low, below low income sites, and one was public and one was private, but they were very, very low income, if not impoverished individuals. And we took 75,000 inhabitants and increased the control rate from about 13 to 14% to 75% in 6 months. In Chile, same thing. In Santiago, we took 5 in a low income or below low income portion of the city. We increased the blood pressure control rate from 20% or less to 87%. And these control rates have now been sustained. It's not a flash in the pan. And they're now going national. Cuba is nationally incorporating the program. The health ministry and the government's just approved this for national distribution. Colombia has states, like we have states. They call them departments. It's gone from the Department of Cali to 7 more states, if you will, or departments, including Bogota. And Chile is going nationally with the program. So what are the recommendations? For a core set of medications for hypertension, must develop this. This is a must. We cannot pick from 150 differing agents. It makes no sense from many, many different aspects, even monetarily or economically. You get a lot more bang for your buck if you can narrow it down and have more volume for a medication than if you don't. We have more leverage, if you will. Select evidence-based pharmacologic antihypertensive classes. We've already talked about the 3. That's not new. Select long-acting agents once a day within each class. They would be preferred over shorter duration agents like I demonstrated for you. But here's one thing that I learned, and I learned it very, very rapidly. Be flexible. Be flexible don't be flexible with the classes, and don't be flexible with the duration of action or the availability of cost, but be flexible with agents that meet all of those criteria. Now, as you saw, all those 4 sites had different medications, had different combinations. And that's the beauty of flexibility. But what they did do was they had everything else standardized. And strongly consider the inclusion of fixed dose combinations if you can, or single pill combinations if you don't have the right combination that you want of the agents. Some are made, some aren't. There's also other complexities. Some come in capsules. You can't split a capsule. And some come in pill form that aren't scored. And some come in pill forms that are scored, which you can split. So there are a lot of complexities in here, but that's the noise in the system. That's the 2% that's left over once you really figure out how to develop this program. So what about an algorithm? You must have an algorithm. Just like the example I showed you, the Kaiser Permanente algorithm, every one of those 4 countries has a standardized algorithm of when you see the patient, when you see them back, the dose titration. They're musts, not unless there's other things going on. They're not optional. You must increase the dose and titration. So it must be simple, and it must be targeted to the primary care individual, whether it's the gynecologist that's the primary care provider for that woman, or whether it's the general practitioner, whether it be a family practice, whether it's our other healthcare professionals. They have to be the hardest thing we had, and we almost wanted to ban them, was we almost had to ban specialists from being on these committees. The cardiologists in Chile were crazy. You know, and I love them to death. I just love them to death. But they wanted every little algorithm, you know, little over here, this exception. The nephrologist wanted, well, what about proteinuria of 305, you know? No, this is not for the exception. And there are exceptions, of course. It's for the rule. And the vast majority is what we're trying to control. So don't address the exceptions in your algorithm. Don't address the exceptions in your formulary. Address them on a clinical basis, and then, of course, with our colleagues. Use complementary classes, I said, and we should use fixed-dose combinations if we can. Some of those, by the way, the four countries with their combinations, some are fixed dose, and some come in the combination in that region or country. But I don't care. That's not as important to me as giving the two drugs. It's better if it's a fixed dose because it's just more convenient. It just makes more sense if it's there. But don't be a slave to fixed dose because you can give single pill combinations. So that's hypertension, and that is where we're at now. The global hypertension program is now expanding rapidly. I've just received word that those were the first 4 countries. We're now moving into Costa Rica, St. Lucia, Panama, Ecuador, and Argentina. India, China, and Mongolia are right behind. I've already started getting calls from health ministers in India regarding incorporating the program as we move further to India, China, Mongolia, and then swing back to Africa and sub-Saharan Africa. Well, stroke is closely related to blood pressure. I've already said at least 2 or 3 times today that the target organ that's most closely related to an elevated blood pressure is stroke. Why? The brain sees the blood pressure directly. There is no modulation of that blood pressure. Your central blood pressure goes right to the brain. And for many, it goes right to the capillary bed. The heart is a different beast. The kidney is a different beast, behaves differently, has different autoregulatory mechanisms, but that blood pressure, the brain sees that blood pressure. And it really doesn't have a whole lot of defense, if you will. And that is one of the reasons why it's most closely linked. So let's look at some of the recent guidelines as related to stroke and blood pressure. This is one of the most common consults or calls I get from the inpatient side, but it also applies to when the patient's discharged with a stroke or post-stroke or post-TIA or post-lacunar infarct for our general practices. It's a huge problem here. I think it was Nancy that showed a similar slide regarding the cardiovascular belt in the South. We call this the stroke belt. And South Carolina has the ominous position of being the buckle. So we call ourselves the buckle of the belt. It goes all the way, obviously, from northern Texas. It should actually be down even in the valley now, Ronnie, in terms of what you guys are dealing with obesity and diabetes, et cetera. But nevertheless, it goes through Texas and all the way up through Virginia and even beyond. So we're right in the middle. So we are the buckle. If you want to study stroke or treat stroke, come here. Or some of our neighboring states, because we need you. This is an epidemic, endemic, if you will. And here's the incidence, and also keep in mind it gives me an opportunity that be you male or female, African American or our black population is a distinctly different issue. If you look at South Carolinian whites, this is from Dr. Dan Lackland, our stroke authority here in Charleston at MUSC. He's president now of the World Hypertension League, if you will, and an outstanding individual. He's got accumulated data for ages. And if you can see, obviously, as you age, stroke goes up, be you white or be you black. But if you're African American or black, you're one age group behind. In other words, it's interesting that if you're African American or black and you're 45 to 55, you're really behaving like a Caucasian who's 55 or 65. So it's almost a codon, if you will, or a cascade shift of 10 years that stroke will happen earlier in our black African American population. And it's not just South Carolina. So I want everybody to know that. If we had one group to really, really target, and the ladies in the audience, please spare me, it would be my male black African American population. They're the least adherent The females are actually pretty darn good, but in general, there are diversity and demographic differences, and I want all of us to be aware. Well, we're doing pretty good with stroke in general, so here's the good news. Stroke has dramatically declined over, the last 3, 4, 5 decades. And I'd like to say that that's largely attributable to the control and treatment of hypertension. On the other hand, it's more than that. It's lipids, statins, diabetes, et cetera. But largely, I think most people would agree that this dramatic reduction in stroke is due to improved blood pressure reduction and possibly even control rates. Remember, in the United States, we are only at 50% control rates. So it's kind of embarrassing when I go to these other countries, et cetera, and they say, well, Dr. DiPette, why should we listen to you? I mean, you guys have 55% control rates, and we're already at 80 and 82%. And I said, you don't have to, really. I can go home, right? But nevertheless, we're not all that great, but we're okay. We obviously have to do better. And notice the continuous decline. Also interesting, and this is also from Dr. Lackland and the MUSC group, it's all ages. And the older you are, as you can see, a given blood pressure gives you a higher, based on your age, gives you a higher risk of stroke. Another way of showing that South Carolina data I showed you. So this isn't a young person's disease or an old person's disease. It's every decade you're at risk, but it obviously accumulates as we age. The other issue is that there's different types of strokes, and perhaps they should be approached differently. Certainly in the acute setting, there's ischemic strokes, thrombotic, embolic, and lacunar. There's hemorrhagic strokes. The major one is intracranial hemorrhage, and that's the bane of our existence in hypertension, particularly in our African American community. That's the devastating intracerebral bleed that we unfortunately see all too commonly, and we see these in the 20s and 30-year-old African American males, and we see them in 30-year-old, 40-year-old African American females. This is entirely unacceptable. And of course, then there's other forms of hemorrhage, but they're much less common, but hypertension does increase the risk of bleed in patients with AVMs and subarachnoid aneurysms, although it's not the cause of the AVM or the subarachnoid aneurysm, it increases the risk of rupture, and if it bleeds, it's worse. And then there's TIAs, transient ischemic attacks. Well, these guidelines are just out. So let's look at some of the guidelines for inpatient acute blood pressure management, but it's going to rapidly, within days, go to outpatient management, as most of you know, and fall in our bailiwick for the most of us. If the patient qualifies for intravenous thrombolysis, and these decisions have to be made fast, right, because we have the window of opportunity. So this has to be right in our brains, and immediately, we have to immediately act. If you decide intravenous thrombolysis, before thrombolysis, you must immediately lower the blood pressure if it's elevated to greater than 185 over 110 to less than 185 over 110. And that's to obviously decrease the bleeding risk of acute thrombolysis. After thrombolysis, maintain the blood pressure a little bit. You can go a little bit lower on the diastolic of 185 to 105 for the first 24 hours. Only less than, anything less than. We actually don't want it rock bottom either. So that's why we have criteria of just less than 185 over 105 after, and 185 less or 115 before. Well, what about if you don't qualify for acute thrombolysis? There's a little bleed in there, you're not sure, the window's gone, has expired, et cetera. If the blood pressure is greater than 220 over 110, lower the blood pressure with a titratable, probably intravenous agent, by 15% for the first 24 hours. And this is what's really news. If the blood pressure is 200 over 110 or lower, don't do anything. There's more harm of lowering that. Who in the world would? I would never, 210 over 100, and I would have wanted to lower that blood pressure. Well, right now, that's actually contrary. Do not do anything, because you cause more harm than good. Well, what about if the blood pressure is less than 220 systolic or lower? Yes, you can start continuous intravenous infusion with close monitoring. But remember, if it's higher than that, do nothing, because the brain, presumably the penumbrum, that has still neurons that can be salvaged, they're at risk. And if the blood pressure systolic is between 150 over 100, lowering the blood pressure further does cause harm. So leave it alone. What about if you're known hypertensive? Well, it's okay to restart the antihypertensive therapy to lower the blood pressure to less than 140 over 90. And what if you're newly diagnosed? This is now in transient ischemic attacks or secondary prevention of stroke. And you're greater than 140 over 90, the new guideline suggests and actually denotates less than 130 over 80. So that 130 over 80 again, and that was in that presentation we just heard, and it was in one of those slides for TIAs. And the goal is 130 over 80 or less. And this is the data. The data shows that you can dramatically reduce recurrent strokes when you lower blood pressure to secondarily prevent small subcortical strokes like Lacunes, et cetera, small vessel disease. Lowering the systolic blood pressure to less than 130 or greater is likely to reduce stroke by 20% and significantly reduced intracranial hemorrhage. That's a significant amount by 2/3. And that's the second one, remember. And obviously, if you had the greatest efficacy of lowering blood pressure to prevent what stroke, now this is the chronic treatment of hypertension, it's intracranial hemorrhage, as you can see here. There is no reason to have an intracranial hemorrhage, at least secondary to hypertension, in our country, or now even in the world, because we can lower the blood pressure and prevent them. And they are, as you all know, they're devastating. We talked about the ACCORD trial in diabetes and the accordion trial, but just to reinforce that trial, even in our diabetics, where the initial study showed intensive blood pressure reduction did not significantly improve outcomes, combined, they did improve total stroke. And this total stroke reduction with more intensive blood pressure reduction in our type 2 diabetics is real, as best we can determine, especially now that the accordion data is out where the blood pressure rose again in the same population and the stroke difference disappeared. It's sort of like negative intuitism. The blood pressure went up and the strokes came back, kind of thing. So this reduction, even though it was a small amount of individuals, I firmly believe that this reduction in stroke is real. And that's where our diabetic guidelines to lower the blood pressure less than 130 over 80 in our diabetics has now been reinserted. Remember, it was in JNC 7, it got lost in JNC 8, and it's now back in with the ACC AHA guidelines. And I firmly support this. And here they are. So again, they're here for you. I did the stroke ones. For secondary stroke prevention, lower the blood pressure at 140 over 90 or greater, target 130 over 80. But lacunar and hemorrhagic stroke, secondary prevention, start at 130 over 80 or greater and less than 130 over 80. So they're in that menu, if you will, of primary and secondary prevention. Okay, now I think for me this was the most fun part. I was told, just think about what's happened in the cardiac world within the last 24, maybe 12, 24 months period, and what's kind of new. So I just didn't use my own self and my own judgment. I consulted Journal Watch. I consulted the New England Journal of Medicine because they have lists of what they think are the most prominent. And I just picked a few because for sake of time. I picked 4. One is we have new congestive heart failure guidelines. That was a no-brainer. So we'll now complete the guideline journey with congestive heart failure. And then there's some really interesting clinical trials that may just pass us by and or may have significant impact in our practices, and I tried to choose them. Heart failure guidelines just came out again last year. And they were recently updated. Again, the same committee, the ACC, not the same individuals, but the same sponsoring organizations, ACC, AHA, have developed new guidelines for the treatment of congestive heart failure. And there's been some significant changes, all that welcomed in this case. Number one, they always address biomarkers. Just like Dr. Phillips talked about biomarkers for ovarian cancer, we always wish there's this magic biomarkers for congestive heart failure that we could use to start treatment and follow and et cetera. and we'd have this whole panel of them, and right now the answer is no. Other than the natriuretic peptides, which may be useful to diagnose suspected heart failure, unless you're Dr. Wagner and you got that little gizmo on there. And it may be of some value in guiding therapy, but it's not clear. So it's not highly recommended. If you're not doing them, no one would fault you. We are actually probably overusing and or using and embracing natriuretic peptides for the diagnosis of heart failure. But we're not using, or to the large extent, we're not using natriuretic peptides to follow therapy. What about RAS inhibition? The new kid on the block for RAS inhibition is for with reduced ejection fraction heart failure with reduced ejection fraction, in addition to our standard armamentarium, and up until now it's been an ACE or an ARB. Now the neprilysin inhibitor angiotensin receptor ARNI class has been added. And that would be primary therapy in place of an ACE or an ARB. So now it's acceptable to go right to the combination. Again, cost is an issue, but nevertheless, a guideline is a guideline. So this has now been added, so I put it in bold. It's now class 1, and you can now go right to an angiotensin receptor antagonist and a neprilysin inhibitor. And they're a combination drug. So everybody else is using these fixed dose combinations. What's wrong with hypertension? I'm just begging, please. HIV is entirely now combination therapy. Who would I'm going to stop. Avrabipine for heart rate control. We know that tachycardia in heart failure and acute heart is bad. So if your heart rate is above 70, despite maximal doses of beta blockers, now and this is, I think was there before, but now has been strengthened to use avrabipine to reduce heart rate, again, in individuals where maximal beta blockers were not tolerated, nor still reducing heart rate to less than 70. I keep telling my students and residents, you only got so many heartbeats in your life, use them sparingly. What about heart failure with preserved ejection fraction? That is a conundrum. First of all, it's much more prevalent than we've ever imagined now that we're doing more sophisticated echoes. And the prognosis with heart failure with preserved ejection fraction is just as poor, if not actually worse in some areas, especially sudden cardiac death, than individuals with reduced ejection fraction. So reduced ejection fraction has got all the publicity, and now we should be paying attention in addition to the so-called diastolic dysfunction, the heart failure with preserved ejection fractions. Ejection fractions of 70%, but the ventricle's so stiff, it can't fill, and if you can't fill, you can't pump, you can't deliver. And everything backs up, and you're symptomatic, et cetera, and you have sudden cardiac death. Well, there's still no magic bullet. There's been several new studies that were negative, including spironolactone, et cetera, except for some subsets. So if you want, clearly aldosterone antagonists or ARBs may be considered, but they're not really recommended. Again, we don't have a magic, if anybody wants to become a bajillionaire, would you let me know, please, ahead of time? This would be an unbelievable population for a magic bullet. For hypertension, we've already looked at some of the guidelines for either reduced ejection fraction, or I'd even make a stronger case for preserved ejection fraction. The optimal blood pressure reduction is 130/80 or less. And I would say that the only thing that's been shown to help preserved ejection fraction has been blood pressure reduction, in addition to heart rate slowing the heart rate. Other modalities they considered, some people have been using intravenous iron, do not, unless symptomatic. EPO is of no benefit, so that is kind of now gone. It's come and gone, like many other areas for EPO, it can do harm. But this is new, do screen for obstructive sleep apnea now. It's now so prevalent. What about recent cardiovascular studies? Those were guidelines, now the fun part. Well, let's talk about 4 publications that came out, some that may have more immediate impact and some that are food for thought and maybe something down the road, but still tantalizing. The COMPASS trial, this could potentially be a game breaker and a game changer. We've obviously been using direct-acting anticoagulants, et cetera, for multiple entities in the cardiovascular field, but we've never used them for individuals with just coronary disease or peripheral vascular disease a priori. There's no indication. So the COMPASS trial studied individuals with CAD and peripheral vascular disease, and they compared a direct-acting anticoagulant here to, at one dose, to the agent plus aspirin, and then aspirin alone, which would be our standard therapy at this point in time. So we had 2 experimental groups and 1 standard therapy group to see what happens. It's kind of a crazy idea, but wow, did it work. There were 28,000 patients in this study, and it was stopped early by the safety committee, not for adverse harm, but for benefit. Very similar to the SPRINT trial. I didn't tell you the SPRINT trial was stopped early because of benefit as well. But this was stopped early. The direct-acting anticoagulant plus aspirin was superior to either the direct-acting agent alone or aspirin alone in decreasing CV events, and there they are. And there was no significant difference between these 2 groups. The 4.9 and the 5.4 were not different, but the anticoagulant alone plus aspirin was far superior. If we can put this, or with cost, et cetera, into our paradigm, then what's the implications? The bleeding rates were slightly higher. But the interesting thing was there was no difference in efficacy based on age, sex, race, or ethnicity. It worked in everybody. So there was no gender differences, there was no ethnicity or race differences. So what's the clinical implication? It's potentially huge, because this is the first study in this population, and it's a game changer. And the issue, however, now is cost and polypharmacy, adding more stuff to people that are already on a lot of stuff. So look and pay attention, look up the COMPASS trial if you want to know a little bit more. We talked about this with one study. This is another study. This was a large study looking at LDL cholesterol at baseline and intensive lowering of LDL cholesterol and morbidity and mortality. And the background is intensive lowering has been shown to be effective. But does the baseline LDL cholesterol matter? We talked about the Odyssey trial, where in that trial it did seem to matter, but that was only one study. What about all the other studies if we put them together? This was in JAMA this year, meta-analysis of 1 jillion people. And it turns out that it matters. Intensive lowering of LDL cholesterol progressively decreased total mortality, CV mortality, and major adverse cardiac events, but only if the baseline level of LDL cholesterol was greater than 100. So it actually followed what the Odyssey trial showed, only now putting all the studies together, so I saved it for today. So maybe if we're worrying about these billion-dollar drugs to lower LDL cholesterol down to 30 and 40 and 20, the expense right now is pretty exorbitant of about $10,000, $14,000 a year. Maybe this will help us triage, if you will, individuals where maybe that is more cost effective, and maybe individuals where we should just leave well enough alone and watchful wait. I do not know. This just all came out, so this debate is occurring as we speak. There was a question this morning about monitoring, intrapulmonary monitoring of PA pressures. I didn't expect that question, but that was very, very interesting because it's been very, very exciting. I don't usually talk about device therapy, et cetera, because I'm a mutt, I'm a generalist. I could have brought that data for you too, but I actually picked different data, and that is trans-aortic valve replacement externally versus surgically, TAVR, if you will. There's been an increasing interest in TAVR. There's been an increasing interest in the number of TAVR procedures that are being done, not only in my community, but regionally and nationally. Up until now, we've only been doing TAVR that's artificially replacing with devices the aortic valve in patients with severe aortic stenosis. Well, that's a very limited population. But what about individuals with intermediate risk aortic stenosis that otherwise would have gone to surgery, where it was surgically indicated? It's still a significant procedure, valve replacement, opening the chest, et cetera. Well, That's our background, and it's a growing problem as we all age because severe aortic stenosis is not only still exists, but it's actually increasing in prevalence because we're aging, largely. So TAVR versus surgery in severe AS in intermediate risk individuals. This is already approved and done standard for high risk patients. But what about the next step down? And sure enough, there's been a study. A recent study showed that a new self-expanding device, if you look at death, disabling stroke, TAVR was 12-ish%. Surgery was 14% at 2 years. Not significantly different. That's good. Because there's no difference, at least in this study, with intermediate risk individuals. However, the complication rates were different. It's, pay your price and take your choice. TAVR caused more valve leakage and more pacemaker implantation, but surgery had more atrial fibrillation and acute kidney injury. So it's sort of a trade-off, but the bottom line is this is a high-risk population anyway. It's a high-risk procedure. The differences between TAVR and surgical replacement of the aortic valve were not different. So now that opens up another patient population where it could possibly be considered as the primary therapy. And this is the last one, and we'll conclude. This is the one I think that is food for thought and really generates some new potential information that on the good side, if it's true, and I'm going to tell you what the it is in a minute, if it's true, it could potentially have a huge effect on not only primary but secondary prevention of coronary disease. But the downside is going to be I'm dreading any information on this area because of the cost of biologics, particularly as we see them entering our cancer colleagues, our rheumatologic and autoimmune colleagues. These are highly expensive agents, and I'm scared to death. On the other hand, science is science, and let's look at the science. We've always known, and we've always suspected, that inflammation plays a significant role in coronary atherosclerosis, but more importantly, plaque rupture. And it's the plaque rupture where, boom, that's it. You either have had your MI and your arrhythmia, and it's a fatal event, or you make it to the hospital and you have acute coronary syndrome. There's no secret that inflammation plays a role in the soft plaques, and ultimately probably even plaque rupture. In stable plaques, it may be less so. But those aren't the ones that get into acute trouble. But there's been some rudimentary studies looking at antioxidants, et cetera, folic acids, aspirin, to some extent, but also your vitamins, your vitamin C's, without much success. But what if you directly targeted a mediator of the inflammatory process that we know is involved, or presumably involved in plaque formation and rupture? Well, that was done. Again, Dr. Richter and colleagues in New England Journal of Medicine late last year, so it's within 12 months, studied 11 subjects. And this was, again, a paradigm shift for a study. They had to have a previous MI, and they had to have high CRP levels because, again, this was an anti-inflammatory study, but more importantly, Dr. Richter was the one that discovered high-sensitivity CRP, and you got to remember that in this. But nevertheless, they randomized patients to 3 doses of an antibody that inhibits interleukin-1b versus placebo. So specifically targeting one mediator of the inflammatory system. Would it make a difference? Well, after 4 years, it did. First of all, it definitely did decrease the inflammatory marker, high sensitivity CRP, in a dose-dependent manner. The more you gave, the lower CRP went down. But it also resulted in a modest decrease in primary non-fatal MIs. However, it's complicated. There were higher fatal infections, but it also was anti-cancer, and there was no difference in mortality. So really, basically, this was a proof of concept study. It proves that perhaps with the right targets for inflammation, that you could get the benefit and maybe not the adverse consequences of direct targeted therapy for coronary heart disease against mediators of the inflammatory process. And again, I wanted to end with it because it's kind of like, it's out there, it's part of the future. Every other disease state where we've used anti-inflammatory mediators has eventually been positive and has changed patients' lives and disease progression. I will just watchful waiting in this area. I'm scared about cost, but excited about the science. So thank you very, very much again for having me during the week.